Our final speaker, back to the issue of primary tumor in a site that makes surgical resection for cure very difficult due to the anatomy of the condition and the fact that in order to spare function, sometimes of necessity, tumor cells get left behind. Dr. Chandrajit Raut is the surgical director of the Sarcoma Center at Brigham Women's Dana-Farber Cancer Center, and he's going to talk about the work of his team in dealing with the issue of local tumor recurrence in sarcoma.
Thank you, and I'd like to thank Dr. Bertagnolli and Dr. Haber and the steering committee for the opportunity to present our data. Sarcomas are rare neoplasms. They account for approximately 1% of all malignancies, and approximately 12,000 patients will be diagnosed with sarcoma in the United States this year. These are largely tumors of mesenchymal origin, and they can arise in almost any tissue in the body, including bone, muscle, as well as the muscular layers of the viscera. And there are more than 50 major subtypes, each of which have their own unique behavior and their unique pattern of recurrence. Retroperitoneal sarcomas, as shown here, account for approximately 15 to 20% of all sarcoma subtypes. And as you can see, these are three different patients that have very large, well-differentiated and dedifferentiated liposarcomas. The well-differentiated component is in black, the largely fatty component, with the more solid tumor component. That's the dedifferentiated liposarcoma component to it, often embedded within a larger, well-differentiated area. And you can see that on the top panel on the axial views, the tumor is largely displacing all the viscera from the patient's left over to the right. And the panel on your left, on the bottom, you can see that basically in this gentleman, all of his tumor is displaced up into his left upper quadrant. And in the other third panel, you see a tumor which has two solid, dedifferentiated components encompassed by a larger, well-differentiated area, essentially encompassing the left kidney and occupying the entire left retroperitoneum. And so due to the complex anatomic relationship and the physical constraints of the retroperitoneum, it is not surprising that local recurrence is the predominant pattern of failure for these patients. In data compiled from 8 high-volume institutions, sarcoma institutions at 8 different countries that we recently published, local recurrence is the predominant pattern of failure, and you see that dedifferentiated liposarcoma, that's DDLPS, recurs over 50% of the time in a local regional manner. And so local regional recurrence is actually the predominant cause of mortality in these patients. Many of these patients die from progression of the local regional disease rather than distant metastases. So hypothetically, anything that we can do to try to improve local regional control should improve survival. This has been looked at in a number of other malignancies. HIPEC, or heated intraperitoneal chemotherapy, has been evaluated in a number of peritoneal malignancies. And what this involves is circulating heated chemotherapy through the peritoneal cavity after the tumor has been largely debulked. This has been quite effective for adenocarcinoma arising in the appendix, but has been largely ineffective for sarcoma. Radiation therapy is effective at controlling sarcomas that arise in the extremities, but its utility in retroperitoneal sarcomas is still unknown. One of the concerns is that there could be considerable toxicity, and some of the organs that surround the retroperitoneal tumor, such as small bowel or liver, cannot tolerate the doses that are effective for sarcoma. Preoperative radiation therapy is currently the subject of an international phase 3 trial randomizing patients to surgery, which is the standard of care, versus pre-op radiation plus surgery alone. The Dana-Farber Brigham Women's Cancer Center is the only site enrolling patients in the United States and one of only 2 sites in North America. It's largely a European study. And the data are not going to be available until 2020 at the earliest. The study is accruing rapidly, but it's going to take a while to look at local recurrence rates. Let's see. So Gliadel has been something that has been found effective in gliomas. These are firm wafers that are placed in the site after resection of a brain tumor, and they elute carmustine over a period of about a week, and the wafers are dissolved or completely dissolved after about 2 weeks. So this is an attractive option. IV chemotherapy has not been effective for primary retroperitoneal sarcomas, but local delivery of chemotherapy in a similar manner is an attractive option. However, there are several challenges with Gliadel that make this particular model unworkable in sarcomas. First of all, these wafers are only about the size of a quarter, whereas the average size of the sarcomas that Dr. Bertagnolli and I remove is about 25 centimeters. So we need something that's a larger scale. Also, the drug is eluted after about a week, whereas most sarcomas are slower growing than gliomas. And so we need something that's going to target cells over a longer period of time, and thus we need something that is going to be present for months rather than weeks. Third, these films are these wafers are rather stiff. We need something that's a little bit more flexible to contour to the cavities within the abdomen. So together with Yolanda Colson, one of our thoracic surgeons, and Mark Grinstaff, a biomechanical engineer at Boston University, we've developed a polymer film that has various side chains that can be altered to help us with loading drug onto the film. So we've been evaluating the drug paclitaxel, and we've tweaked the side chains to allow slow release over a period of about 60 days or more. And the films themselves, as you see in the image on the right, are rather flexible. This one was cut just the size of a centimeter for our mouse model. And they continue to elute paclitaxel, which is the payload drug that we've tested most often, over more than 60 days. So that's an improvement on Gliadel. Plus the flexibility allows us to contour it to the various cavities within the abdomen. So once we had this film ready, we then developed a mouse model of recurrent sarcoma, something that mimics what we see with retroperitoneal tumors. And so using a cell line, we developed a mouse model that has a recurrence rate after resection of the tumor of about 80%. So what we did was then we randomized mice after resection to one of 4 arms to get paclitaxel eluting films placed into the tumor bed, covering just the surgical bed, films that did not have any drug, IV paclitaxel but no film, and just surgery alone, which is the standard of care. And what we found was that the mice that had the film with drug had a higher or a lower recurrence rate than any of the 3 control arms, suggesting that, and just in a small model, this was still statistically significant. We also found that there was some improvement in overall survival as well, with the paclitaxel film arm significantly having better survival than the unloaded film or the Pax IV arms did. We then looked at, in a separate cohort of mice, the local tissue impact. So we looked at basically local tissue levels of paclitaxel in mice that had the film implanted. And what we found was that, this is a logarithmic scale, was that there was sustained release of paclitaxel. We stopped measurement at 30 days, but in additional studies we've done since then, we found that this drug elution continues beyond 60 days, whereas there's very little IV paclitaxel that is detectable in tissue after the first day. We also looked at plasma paclitaxel concentrations, and again, on a logarithmic scale, you can see a high dose in the first 30 minutes after administration of paclitaxel. In mice, we use the same doses that are standard of care for, say, breast cancer or sarcoma. And then there's very little detectable paclitaxel from the films in the bloodstream. So this is basically a model that allows us to give local treatment to the tumor bed, which is the predominant site of recurrence, without any systemic absorption. So now we've developed another generation of film that has, in addition to the flexibility seen on the original films, also a property of elasticity, which allows us to affix it to structures such as the diaphragm, which are moving constantly without ripping the film. And these films can be loaded with a wider variety of drugs. And so now we've received a grant to look at several components. First, to look really at the mechanism of action. Our preliminary data suggests that the mechanism of action when you deliver a high dose to local tissue is very different than the mechanism of action of the same drug, paclitaxel, given IV. So we are going to develop, we're using our patient-derived xenografts, and we're taking thin tissue slices and placing film on them to look at really the mechanism of action. Secondly, using the patient-derived xenografts, we're also going to look for local recurrence rates. And third, we're going to look at the potential toxicity in a large animal model. So I'd be happy to take questions outside. Thank you.